All right, I think we're going to go ahead and get started this afternoon. I'd like to welcome everyone for coming, both all of you here in the audience and also those of you who are watching online. I'd like to thank all of you for being here, and it's great to see such a great response from folks who are here in the audience and also from those who are online. And I think it's really a reflection of the importance of this issue. I'm Clarence Lamb. I'm the Chief Resident of the Preventive Medicine Program here at Johns Hopkins Bloomberg School of Public Health. And today we'll be talking about the AllPayer system here in Maryland. And I think it's really an important issue for a lot of us, particularly with increasing healthcare costs and hospitals being asked to do more to coordinate care and play a central role in a lot of the provisions of the Affordable Care Act. And with the exchanges coming into play in 2014, there's a lot going on in the healthcare space that there's no one better to have talked to than Mr. Robert Murray, who's the former executive director of the Health Services Cost Review Commission. So with that, I'd like to welcome all of you. If you could please refrain from asking questions during the presentation, kind of hold them with you towards the end of the presentation, that would be great. For those of you who are viewing it online, there should be a link to the right of the page that you can click to submit questions online, and we'll be able to take the questions that way. In the past, we've had Dr. Miriam Alexander run the introduction to our speaker, but she is ill today. So, we appreciate Dr. Tom Burke, who's able to be here. He is the Associate Dean for Public Health Practice and Training, also a professor in the Department of Health Policy Management, and former Deputy Commissioner for Health in the state of New Jersey. We really do appreciate his effort to be here. When things fall through, we know who to turn to, and we're glad that oftentimes when a speaker can't come or someone can't make it, you go down the list to find someone who can actually come in and pinch it for you. We decided to take the opposite track and go up the list. So we're glad that Dr. Burke was able to come in because we didn't have much farther up the list to go. So, and with that, let me turn it over to Dr. Burke.
Thank you, Clarence. Clarence, if you didn't save my life when I got that spider bite, I don't know if I'd be here today to do this, but it is a pleasure, and it's nice to know I was your first pick. Right? Anyhow, what more timely an issue than this? And I want to thank all of you for being here on our challenging rainy day, and those of you watching online, welcome as well to the annual J. Douglas Coleman Lecture. This lectureship was established in 1974 in honor of Mr. Colman by his dear friend and the President Emeritus of the Johns Hopkins Hospital, Dr. Russell Nelson, who delivered the very first lecture. Mr. Coleman's two daughters later endowed this lectureship so that it can continue to be presented for students, faculty, and all those who have an interest in public health, to be inspired and informed on the issues of the day. In 1939, Mr. Colman helped launch the Associated Hospital Service of Baltimore, the city's first nonprofit health service plan. That plan presented a unique approach, combining insurance and health care that promised health coverage to clients and payment for services to providers. He charged 75 cents a month for the plan. Not bad. Just like we pay right now. $9 a year. In time, this innovative approach to healthcare became a great success, eventually becoming a company that most likely touched all of us, Blue Cross Blue Shield of Maryland. From 1947 to 1951, Mr. Colman was appointed lecturer at our school, then called the School of Hygiene and Public Health. Some of us old geezers still slip and call it the School of Hygiene, but here he studied epidemiology and biostats and public health administration. The risk sciences were not invented yet, or he would have taken the risk course. That's an inside joke. I teach that for those of you online. From 1951 to 1957, he joined the Johns Hopkins Hospital as vice president for development, focusing his considerable talent on the area of fundraising. And then rejoined the healthcare plan movement, eventually becoming president of Blue Cross of New York. Mr. Colman was an active proponent of voluntary health insurance and played a major role in establishing and expanding Blue Cross coverage for thousands of Americans. His enormous accomplishments in helping to provide Maryland citizens with affordable access to quality health care and his contributions to the hospital and the university is why he is honored here today. So I'm very happy today on behalf of the General Preventive Medicine Residency and the school to welcome you to our annual grand rounds and to introduce today's speaker. So Clarence said a little bit about Robert Murray. What more timely issue? I heard Robert speaking a little bit before I came up here, and he's saying, boy, it's going to be an interesting couple of years. It is going to be an interesting couple of years. Well, what a fascinating year as we watch the events, particularly relating to healthcare, but relating to the national politics and the future. Robert Murray is the president of Global Health Payment, a management consulting firm specializing in the design and implementation of pay-for-performance, episode-based, bundled and global payments for healthcare providers. In addition to his consulting responsibility, he's a writer and health services researcher. And a very important lens he has for today's perspective is that he served for 17 years as the executive director of the Maryland Health Services Cost Review Commission, HSCRC, Maryland's AllPayer hospital rate setting agency. Under Mr. Murray's leadership, the HSCRC initiated a number of very innovative payment programs, including the nation's first severity-adjusted DRG-based payment system. And you could read about the other accomplishments on the brochure. He's currently assisting representatives of Vermont. Lots of action on the state level now on the implementation of health reform. And he's assisting Vermont in the development of an all-payer global budget payment structure for all the hospitals and physicians in the state. He's a frequent lecturer and presenter internationally. He has worked as a consultant for the World Bank on a number of assignments related to healthcare reform initiatives around the world, including the Russian Federation, Brazil, and India. And he received his Master's in Business Administration, his Bachelor's and Master of Arts in Economics from Stanford University. Not a bad place. So please join me in welcoming Robert Murray.
Thanks very much, and then thanks for everybody braving the weather to come out to see this and people on the webcast. I'm not just going to talk about the HSCRC. I wanted to try to set up the topic a little bit and build a case for why we need a comprehensive approach to payment reform in this country. And then I will discuss, use the Maryland experience as a bit of an example, a laboratory for how to get there potentially. But before I get started, I wanted to kind of make just a little statement, a disclaimer. I'm going to try to speak somewhat candidly about a topic that I think is of vital importance, not only to future patients and the healthcare sector in general, but also to just the overall social and economic infrastructure of this country. Healthcare and healthcare financing plays such a vital role in our society, and certainly there are millions of people who devote their lives to producing the very best care they can for their patients. But unfortunately, we have very, very profound problems in our health sector. So that if there's any hint of an indictment in my presentation today, it's really not directed or meant to be directed to those who sincerely have the best interest of their patients at heart. Instead, it's more directed at the incentive structure in our country, particularly as it relates to the financing of healthcare, which I believe is really not structured to be in the best interest of populations that seek care either now or in the future and ultimately pay for it. It's a structure that certainly can be quite exceptional. Right now we have such amazing technological developments and the ability to provide care. And I think we all know it has problems, but it can be quite good. And I hope this lecture, this presentation can at least illuminate the ways in which we can steer our system to be moving more in that direction. The other thing I wanted to mention, too, is the first part of this presentation borrows very heavily on work that Dr. Uwe Reinhardt has done more recently in looking at the issue of market failure and also potential for implementation of a broader payment structure. So as we get into the lecture, I will try to emulate Dr. Reinhardt as best I can with my German. That's more like an Eastern European version. But if I start to channel Uwe, please let me know. So trying to move on here. Here we go. Topics to cover today. Finally, I guess I wanted to address the fact that there's been good news recently about healthcare costs, that they seem to be coming down. So I want to ask the question, have we finally addressed this healthcare juggernaut? And then take stock, take a look at fundamentals and also long-term trends to answer that question. A look at the history of growth in the U.S., comparisons to other developed countries, and really try to figure out why we're different. We'll focus on the primary drivers of cost growth, which I believe are the market failures that persist and haven't been addressed, particularly in the United States, and focus on what I think are very profound implications of not addressing healthcare costs. As I said, my role here today is to make the case for a coordinated comprehensive payment system, and spotlight Maryland as kind of a case study or example. I'll talk also about what I see are the glaring weaknesses of payment systems and a way of potentially how we can reinvent rate-setting models. So 2009, 2010, lowest cost growth in 51 years. Have we broken the back of the healthcare monster, healthcare cost monster? We had this headline from CMS most recently. Healthcare costs only grew at 3.9%. These last 2 years is the lowest rate of growth is in the 51 years of tracking national healthcare expenditures. We had Karen Davis from the Commonwealth Fund with this quote: "The tectonic plates underlying the healthcare system are beginning to shift now in anticipation of the new incentives under healthcare reform." We've heard this type of statement before, and certainly there's a lot of optimism that maybe there is indeed something fundamentally different here. The Wall Street Journal had this editorial recently, "The Myth of Runaway Health Spending." It was a revelation for me that I've been living a myth the last 40 years. So this fellow J.D. Klein indicates that the moderation has been driven by cumulative improvements in medical care insurers, marketplace disciplines, as well as consumers who we are finally now getting more involved in managing our health care, which is a positive development. You see this graph over here. But I think what we need to do is really examine the key trends over time. It'll give us a better picture. And actually, the longer-term trend looks rather ominous for me. This is a chart that came from a blog from Uwe Reinhardt's New York Times blog, Economics. And you can see that things, although they perhaps have flattened out the last couple of years very slightly, they're headed quite ominously upward. We do see that consumers are spending more or not. Medical bankruptcies are up. There is a great deal of cost sharing, cost shifting that is going on to the consumers. So at the lower end of healthcare, maybe that's helpful in trying to make consumers more prudent purchasers. But it's really hard to shop when you're sitting in the back of an ambulance going to an emergency room. Try to figure out what service, what ER that you want to go to that's most cost effective. We also see that the increasing role of Medicare and Medicaid over time, such that by 2020, we expect that the public programs are going to be funding about 50% of total health expenditures. And there's this dynamic of we don't want to raise taxes to fund healthcare more broadly, so what do? We have an implicit tax through higher prices in hospitals and physicians on the private sector, which continually drive up prices for commercial insurance. So that's kind of the general overview. In terms of longer-term structures, the real question is this excess cost of national health expenditure over the growth of GDP increases year to year going to moderate over time? And here's another chart from Uwe's blog, which shows on the blue line, which is the percentage growth of national health expenditures over GDP relative to the growth of GDP, which is the red line. And we see that indeed the national health expenditure line appears to be declining, that blue trend line, but GDP is also declining. So the real question is, have we really reined in this growth of healthcare? We're still growing at GDP plus about 2%. And it begs the question, when are we going to get down to GDP growth or GDP plus 0.5% or 1%? And then there's this other chart, which it came in an article that was done by Henry Aaron or Drew Altman a couple of years ago, back in 2003. He labeled the sad history of health reform in one chart, which focused on this excess growth of GDP plus 2% for national health expenditures. You can see that the line is relatively flat, though trending down a little bit. And so it's tempting, based on 2 years, to say, okay, we finally turned the corner. But if you look at this longer-term trend and what we've witnessed back 40 years, we find the case of what Drew Altman observed, which is that no approach so far in our nation has had a lasting impact. We had the enactment of Medicare and Medicaid 65, and it had an impact. Wage and price controls in the 70s had an impact. The voluntary effort of providers in response to the Carter proposal for an all-payer system nationally in 1976. And then implementation of the DRG system nationally had an impact. Managed care in the mid-90s had an impact, and then it bounced back up. So it really begs the question, have we broken the back of healthcare inflation nationally? Uwe thinks it's too soon to break out the champagne and celebrate. And I think it's worthwhile also to take a look at our footprint relative to other nations. We can take solace in the fact that healthcare costs are eventually going to moderate. I mean, we're not going to get up to 100% of GDP. And we have seen this gradual decline. It may be that the marginal utility of healthcare to us consumers is declining and explaining that decline. But we're still dramatically above the rest of nations, industrialized nations. You can see the U.S. and that chart on the right really shows that demographics doesn't change it. We're about 12% of the population over age 65, and we're about double nations that are 18, 20% of their population over age 65. So it's not demographics. And we just take a much larger bite out of the GDP cachet than any other nation. And you can see Germany, Italy, and Japan out there to the right with about 20% of their populace over 65. So it's not demographics. We know it's also not better value. We've seen quality statistics to show that we overall don't provide better healthcare quality. So why are we so much more expensive? Well, my theory, it's back to massive market failure in the healthcare sector. And things like nature of the good, it's our health, is something we value. Moral hazard, the presence of insurance, which causes us to use more. Complexity, the difficulty in shopping unless you've gone to medical school and understand all of these medical issues. Non-standard products, asymmetric information, and the general dominance of providers that are things that really prevent us from being able to have a functional competitive market. And that produces things like supply-induced demand, suboptimal market structures, non-price competition. And three things I want to focus in on today, which is irrational pricing, our pluralistic and highly fragmented, highly complex payment system, and the basic lack of purchasing power, which we have here, which is in stark contrast to every other industrialized nation, which has fortified the buy side market power of purchasers. And as a result have lower healthcare costs. So, again, looking at these three issues, these I think are the fundamentals that I want to try to step through and emphasize. First, dysfunctional pricing. I think we all know the importance of the pricing mechanism in competitive markets. It's the means by which you get millions of decisions between consumers and producers that help determine the proper allocation of resources. It serves that signaling process that signals preferences of consumers and sets an equilibrium price for the market, allocates supply and demand. It's that invisible hand, which the market remains dynamic and efficient, also requires certain conditions to be functional. And those conditions, I maintain, do not exist in the healthcare market. So by contrast, in healthcare market, we have this, what's been described as this Byzantine melange at different bases, different prices across the board, and that's Uwe's observation. More recently, since 2006, we've started to get a better picture of healthcare pricing nationally, and data from California, New Jersey, New Hampshire, and Massachusetts show that prices are all over the map. In fact, there's a famous quote from the CEO of University of California Medical Center at Davis, who said there's no method to their pricing madness. And even the administrators will admit to that. We have basically a fragmented system with no relationship to underlying costs that sends the wrong signals and doesn't encourage efficient, effective outcomes or allocation of resources. And it's definitely not consistent with what you would expect as a competitive result. So what are the implications? Well, there isn't really transparency in terms of pricing. That's one implication to this. But when we do actually have the data to see pricing, it's exactly as I mentioned, multiple prices for the same service for each provider. And there are huge variations of pricing for similar services across a given region and within smaller areas. And these incentives drive behavior. When you have skewed incentives, they motivate activities that lead to higher costs. And misallocation, as I said, over and under supply. In general, just a lack of incentives directed at producing that higher value care, which is efficient care and effective care, high quality care. And it contributes also this variation to what Uwe calls as a very splintered system for healthcare financing. So taking a look at this system, it's a pluralistic system. There's nothing wrong with that inherently. I think it's something that we can deal with, but it does augment that fragmentation. We've got Medicare, Medicare Advantage, the TRICARE, FEHBP, which is the Federal Employee Benefit Program, Indian Health Service. We've got Medicaid, fee-for-service, MCOs, each state having basically its own system. And then we've got over 2,000 private insurance companies, which all individually have their own systems, their own claims processing and adjudication for the most part, as well as their own tendency to negotiate individually with providers. We've got the hospital and the provider sector, which I have labeled as a bunch of H's down here, and it all mounts up to this highly fragmented and complex system which contribute to these high administrative costs that we have. And then what we also have is that fragmentation creates these various silos around providers that isolates providers and penalizes them for trying to coordinate care, to reach out outside the hospital to long-term care, to physicians, and coordinate care actively within an integrated delivery system, which for the most part doesn't exist. So we have this hugely complicated, fragmented system. Money flows from households to providers through a vast network of uncoordinated pipes or capillaries. That's a quote from Jerry Anderson's famous piece in 2003 about hospital pricing, healthcare pricing in the United States. And in this figure, also from one of Uwe's articles, it shows this fragmented flow through the various pumping stations that we have from households, finally to the ultimate providers of care. And not all of this money flows to providers. We get legions of non-clinical enterprises. There's so-called value chain within healthcare. This is from Michael Porter and Teesberger's article, or book rather, published in 2006, also shown in Uwe's most recent article. You have the clinical and the related enterprises at the bottom, but then you have this top box, which tends to suck off a lot of resources and funding with adding relatively little value to the overall equation. And most industrialized nations do not have this type of extremely complicated structure. And it basically what we've created is what Henry Aaron called, and I want to read this quote. He says, "I look at the U.S. healthcare system and see this administrative monstrosity, a truly bizarre melange of thousands of payers with payment systems that differ for no socially beneficial reason, as well as a staggeringly complex public system with mind-boggling administrative prices and other rules expressing distinctions that can only be regarded as weird. And I would concur. So we have this enormously complicated overall financing system. It creates waste in excess of $100 to $180 billion a year. I've seen various estimates of that. But 2003 saw a study that showed that on per capita basis, we're 6 times the average of other industrialized nations. And certainly just a tremendous amount of administrative complexity. I've been to Johns Hopkins Hospital. I see the legions of people that they hire to cut through the paperwork and that have been created by largely the private sector that add relatively little benefit overall. And it also contributes to this highly splintered structure that really results in what I would characterize as extraordinarily weak demand, the weak buy side, which I want to focus on now. And U.S. policy over the last 35 years has generally supported this fragmentation. It hasn't done anything fundamentally to address this issue of weak purchasing power. As I said, that's the one thing that differentiates us most dramatically from other industrialized nations. In large part, this dynamic is, I would argue, responsible for this excess cost growth that we've seen, the GDP plus 2.5% over 40 years. And our system is structured to reward not value, but rather consolidation and in generating market power on the part of providers so that they can navigate through this incredibly complex system. And we're witnessing in the last 10 to 15 years increased consolidation of market power over time, and evidence that it's just making things worse. So here's a chart from the American Hospital Association. It shows, at least for hospitals, the percentage of payments hospitals receive as a proportion of their costs. And it fluctuates up and down. It's very tempting to say that there's a correlation here. As public payments go up, then private payments can come down, and vice versa. There may be some relationship there, but I would argue that it is primarily a function of market power and the consolidation of market power in the provider industry. In that, and as Paul Ginsberg has said, the growing market power to negotiate higher payment rates from private insurers, it's the new elephant in the room. And you can see it in this chart here, where now the private sector is being charged 134% of cost. Medicare and Medicaid are heading south. And there is this debate between whether it's cost shifting or price discrimination. I won't bore you with those gory details. Whatever it is, it requires market power to generate this dynamic. And the implication of this is it is an outright abuse of power to increase prices to the private sector. Other evidence of consolidation, what's really, and this dynamic is really behind this to a large extent, is the backlash to managed care from the 90s and the preference of consumers and employee-sponsored health plans to have choice and to have the broadest networks possible. But there is growing empirical evidence, too. I've seen recent articles in Health Affairs from Glenn Melnick and Jamie Robinson that document this correlation. It's consistent with the theory on monopolies and consolidation, that when you get this type of dynamic, prices tend to go up. Paul Ginsberg and also Bob Berenson have published some articles, and we'll be publishing some soon. And it's basically a zero-sum game that encourages the abuse of market power, price discrimination, and so-called cost shifting. Now, one of the implications of this dynamic that MedPAC most recently has observed is about controlling costs, is that they've looked at cohorts of hospitals that are under broad pressure from dominant private payers and also Medicare and Medicaid that keep a lid on prices by definition because of the market structure in those areas. And lo and behold, those facilities tend to control their costs very well in that they have Medicare margins. And this is very consistent with the evidence from Maryland. When I was at the Health Services Cost Review Commission, we would see almost a precise correlation of the amount of money that we'd given rates each and every year and the amount of money that hospitals would spend on their costs. that when things were tight, they held costs down. When things were loose, they spent rather freely. So there is an implication to holding down prices in terms of promoting higher levels of efficiency. There are other more subtle factors that are tilting the advantage towards providers, things like must-have hospitals and specialized services that undermine the negotiating dynamic between private payers and providers, geographic isolation. Hospitals in isolated areas basically can have their way in negotiations. The ability to negotiate a single contract for constituent facilities across broad regions like the Phoenix area or Southern California, and also most favored nations contracts or clauses, where you'll get certain payers like Blue Cross of Michigan who have gone in and say to a health system, we'll pay you what you want here, but you have to agree to charge more to all of our competitors, so that Blue Cross has a competitive dynamic. That's been challenged in court, but that's the type of negotiation that goes on these days. The ACOs and increased employment of hospitals now or physicians by hospitals is not helping the dynamic. It tends to cause those entities to muscle up. And basically, private payers are just acquiescing, just wanting to be slightly better than competition, but otherwise passing premiums on to the private sector. And there are strong incentives for providers to keep this buy-side fractured and weak, and it is a result of the fact that they're rewarded for this. And so what we've done basically is we've created, I think, an engine for reallocating income. And certainly, in many respects, as I said at the beginning, we are the best in the world, and there are legions of professionals who seek to improve the quality of their patients' lives. But they're caught up in this ceaseless struggle over money and the fragmented set of incentives that in this fundamental power imbalance that exists. And this is, again, another representation of our system, and in a quote from Bruce Vladeck and Tom Rice in a piece they did in 2009, that we've created a massive engine for the redistribution of resources from households and taxpayers and employers to those organizations who provide care. And that's the way the system is structured. So implications. Weak buy side leads to price increases in the private sector, and indeed, the evidence internationally shows we are way high when it comes to prices. If you don't believe me, just talk to Jerry Anderson. Other implication is the delivery system. It's a reflection of our payment system. We have a fragmented payment system, so we will have a fragmented, disconnected, disjointed delivery system. Providers fight any credible attempt to control costs, and payers too fight attempts to control costs. As we see in the Accountable Care Act discussion leading up to 2010 with the public plan option, is private payers were against that because they feared having price discrimination or cost shifting taking place when that the public plan had leverage to lower prices. They were going to be cost shifted against, and as a result, fought that cost containment effort. And instead, it's easier to talk about fads or amorphous ways of trying to address or control volumes, address costs, and little ability to address these real culprits of healthcare expenditures, which, as I said, are high prices, high administrative costs, and weak purchasing power. So it boils down to these three things. It's the price is stupid. That was the title of Jerry Anderson's article. Both the irrationality of pricing and also the level. And you can see here another chart from McKinsey Global Institute. This is 1996, but it just shows how prices explain a big portion of the difference between us and other industrialized nations. Complexity, administrative costs, and also lack of purchasing power. And it just really strikes me as we're the highest nation on earth in terms of healthcare costs, and the only nation that doesn't have some sort of government involvement to try to bolster the purchasing side of the equation. Social and economic implications, I think they're quite significant. And you know, we talk a lot about our budget problem and our entitlement spending. It's all healthcare. This quote from Professor Binder from Princeton, we don't have a spending problem. We have an overall humongous healthcare spending problem. That's what's behind the budget deficit. Peter Orszag, the former director of the Office of Management and Budget, says that if we're not able to control this, There are going to be long-term fiscal imbalances, and really our standing in the world depends on our ability to control healthcare costs. Other prominent economists have also raised concern. Joe Newhouse recently raised the specter of us getting up to 80-90% of debt to GDP. Since we don't want to raise taxes, we can't borrow. Otherwise we risk getting into a downward spiral like we see taking place in Europe these days. And basically the structural deficit is on an unsustainable path. And then from a social standpoint, I would argue that we're heading down the path of creating a two-tiered health delivery system in this context that as the federal government cuts spending to try to rein in the budget, we will see higher prices to the private sector. And increasingly, it will lead to a diminishment of access of public sector beneficiaries, both Medicare and Medicaid. And then there's a question about what about the middle class? Can't afford the private insurance, not eligible for the public. What's going to happen? And in fact, I think it's already happening in California. This is a chart that just shows Medi-Cal, their Medicaid program, and Medicare expenditures gradually going down over time and costs being shifted or price discrimination to the private sector. And that directly hits the middle class and employed folks. Other important observations, I've already made this, to fragmented payment fragments the delivery system, but we do have the ability to change payment and move from this largely fee-for-service system to a much more value-driven system, and I'll try to focus on how I think Maryland is attempting to do that now in other states like Vermont. So it needs to be comprehensive. Slowing public spending is not the answer for overall system transformation. These gimmicks like increasing the eligibility age or just cutting Medicare and Medicaid just will shift costs. And the experimentation that exists now, while meritorious, really are not going to be comprehensive enough to rein in costs. So what we need is a comprehensive payment system. There's been recent interest, and I think people are finally realizing that there needs to be some type of overall approach to addressing high prices and the cost of care. Joe White, Jonathan Oberlander in 2009, Ginsburg and Reinhart had an interesting back and forth in health affairs on a blog. Vladeck and Rice, Joe Newhouse surprisingly came out with this statement that he said that all-payer rate setting may be the only feasible alternative to control costs. And then finally, Uwe with a couple of articles which I think have been quite eloquent in articulating these issues. What is an all-payer system? Well, under an all-payer system, you get a public body like my former agency, the Health Services Cost Review Commission, or it could be a quasi-public private body, would have the legal authority to establish prices, both a ceiling and a floor, paid by both public and private payers to all providers. It requires a common unit of payment, so you need either payment per unit, like relative value units, or per day, or per case, or broader episodes of care, embodying both admission, discharge, or even global budgets. It would mandate then a price for a given service at a given provider, and these prices wouldn't vary as they do now across the board for all the multiple plans that exist. And previously, we had as many as 27 states that had some form of rate setting. Only 4 had all-payer systems. That was Massachusetts, New York, New Jersey, and then lastly, Maryland. West Virginia, interestingly enough, sets rates for the private sector. And in combination of Medicare setting rates, Medicaid setting rates, it's a quasi-all-payer system that can be coordinated, and it has been quite effective. All-payer systems have also been, as I mentioned, successfully implemented internationally, in particular Germany, Japan, France, and the Netherlands, and many other OECD countries. Maryland is the last remaining in the United States. So, talk a little bit about the Maryland rate setting system. First, it's not an American model. And when I go internationally and present about Maryland, most people need to hear this because they don't think very highly of the American model of financing. It's the only state to address the rapid growth in costs through this type of system, and it's based on the premise that people respond to financial incentives. And these incentives should be structured then to encourage meeting the policy goals that you've established. Not such a radical concept. Our legislature here believes also that these incentives should be consistent so that people could understand, the people responding could understand the signals that are being sent and then respond to them. And the principal goals that this system was designed to structure incentives around to meet are cost containment, equity in payment, patient and treating patients, access to care, transparency and accountability, financial stability, and lastly, quality. Again, not too terribly radical concepts here. It's also predicated on that original premise that I talked about earlier, which is that healthcare markets suffer from massive market failure. And rate setting should be structured to set prices the way a hypothetically competitive functional market would set prices. That is, relate prices to underlying costs and relatives, reflect variations in relative resource use over time, and try to get the prices right, or at least move them closer to what a competitive market would produce. And this really is, it's not rocket science. It can be done, but it stands in stark contrast to that picture that I tried to paint in the rest of the United States. But you need an institutional platform. So the legislature here set up a central and independent government commission, the HSCRC. It had broad powers of data collection and payment design and implementation. There was an emphasis on comprehensive design, as I said, applying to all, heavy use of data and financial incentives, and also this creed of avoiding excessive market intrusion. Minimal market intrusion or macro regulatory approach is very important. Development of attainable, predictable benchmarks and targets and goals, and also take a long-term view. Healthcare is important. It's important not to disrupt the industry year to year, but rather look to the long term and gradually steer the course to where you want to go. Commission characteristics, politically, legally independent, that's vitally important. Politics plays a huge role in this situation when you have market power. Governance, we have 7 commissioners, the volunteers, professional staff of only 31. We regulate through formula-based rate setting, not detailed accounting-based rate setting, so we can do it with 31 people, and broad powers of data collection for all acute care hospitals. Jurisdiction over all the acute care facilities, $13 billion. No authority over Part B, which is a gap. It's something that sort of makes rate setting rather truncated. Other characteristics, everything's public. There's an emphasis on cooperative rulemaking. In fact, we get payers and hospitals in a room each and every year and try to negotiate payment increases as best we can, so there's an element of negotiation that takes place. And we focus on constraining costs, but not on limiting management decision-making autonomy, which is also characteristic of a competitive market. A competitive market sets an overall cost constraint or revenue constraint, but otherwise gives managers tremendous flexibility to innovate and make decisions to respond to those incentives. And we were similarly structured in that way. And there's flexibility over time and responsiveness to industry changes in the industry and also needs of participants, as well as to accommodate market-based innovations. It's all made possible by this waiver from Medicare that brings Medicare into the mix and makes the system AllPayer. Guiding principles, again, market failure. Legislature also articulated some sound principles in our legislation for setting prices, that they should be prospective, known in advance, set at the beginning of the year, that prices should be related to costs, and also set around where long-term marginal cost is. That's the way a competitive market would work. Prices should be consistent, equitably established. It neutralizes market power, and pricing mechanisms should apply to all purchasers, as I've said, and emphasize also that the level and the structure of pricing are important. The level being controlling price, the price level over time, but the structure is important too. There's a difference in the incentives between fee-for-service or per case, per episode, or global payment. The latter being more desirable in terms of cost containment incentives. The benefits of uniform pricing is you get better allocation of resources, more stability, predictability for management, less administrative costs here because hospitals aren't dealing with 2,000 different insurance companies and different pricing schemes for each of them. You also have a much fairer sharing of hospital costs. It's a much more equitable system, less variation over time, less variation in profitability as well. We tend to have cut off the lows and the highs and provide support for safety net hospitals, no antitrust concerns with regard to pricing, and a basic coherent framework over time to adjust and change the system over time. And in fact, we've done pretty well. On a unit cost basis, we've done very well. These are data from 76 to 2009. We were 25% above the US on cost per case at the beginning of that period, and we're more than 3% below, I think, in 2010 now. It's cumulatively, we estimated we've saved the state about $45 billion relative to had the state grown at the US rate of growth over that period of time. So you can see this cost curve. I think we've indeed bent it down, Maryland being the lower pink line there. And had the U.S. had Maryland's lower rate of growth, it would have resulted in over $2 trillion of savings over that span, which is, I think, fairly impressive. The only caveat to this is it's per case, because we were focused on the unit rate. The negative associated is when you control per unit, providers tend to do more units, and that's indeed what happened in Maryland, which I'll discuss in a few minutes. Just comparing Maryland to the U.S. and the fragmented system, fragmentation dilutes incentives, and you get these unpredictable systems. So you can compare the U.S. on the left-hand side versus Maryland, and the so-called cost shifting, or what I really think is price discrimination that takes place nationally. And Maryland's system provides just a much more coherent platform. And then illustrate this more graphically in terms of markups of hospital charges, what they actually post as their prices, not what's paid, but prices follow in underneath this red line. The markup of charges over cost, Maryland has the lowest markups of any state in the U.S. It's about 20%, whereas markups nationally are up in excess of 200% over cost over time. We prevent that price discrimination, cost shifting, and as a result, it forces hospitals to constrain and manage their costs. We also have less price variation over time. These data came from the hospital HCUP program, which collects discharge data from each state, and shows Maryland as a far less variation over time, or in 1 year, I should say. All right, well, coming back to this overall picture for the U.S., because I do think that you're going to hear more about this nationally. There are going to be a number of papers and articles that will come out proposing finally for a comprehensive and coordinated system of payment. Probably not at the national level, more likely at the state level. Vermont is already moving in this direction. Here are the reasons why I think it's inevitable that we'll move this way eventually. One, it gets us down the road towards more simple administrative costs. It improves transparency and accountability. Those two things are related. It also provides for equitable treatment of patients and equitable financing of healthcare, so that you're finally sharing all costs more equitably across both public and private payers. It can rationalize prices, or at least get them closer to what a competitive market might produce. We have a good record of cost containment, both in Maryland and in the other states that implemented all-payer systems for a number of years, and internationally. The history is quite strong in that regard, and nothing else, quite frankly, will work as comprehensively or as quickly, and I'll show you some evidence of that. It can also be structured, as Maryland has been structured, to be flexible and not rigid as many governmental systems are, to preserve that dynamism in the marketplace itself, and then be a platform for other types of innovations, including innovations on the quality side. Administrative simplicity, it will reduce that complexity of multiple payment systems and multiple prices over time. It won't take out all of the administrative waste, but it will get us on that path towards a much simpler system. And in fact, Vermont is experimenting with what they call a single pipe system, where they would preserve both private payers, they have a Blue Cross plan there and several other private payers, as well as Medicare and Medicaid, but have all the claims adjudicated and processed through a single pipe, a single processor, to try to create uniformity and standardization, which they estimate ultimately could save the system as much as 7%. And then there's this increased transparency that comes with a common claim form and common data across all payers, where you have you can monitor patterns of excessive cost and patterns of care patterns, identify fraud. And again, Vermont, Dr. Shao from Harvard quantified potential savings in terms of reduced fraud and abuse of 5%. An example of that, things we've already done in Maryland, at least analytically, is identify so-called reference pricing of the best combination of physicians and hospitals. So here's an example of a scatter plot of combined physician-hospital cost per case, percentage of adverse events, quality on the vertical scale, and you can identify the average of all of this cloud of data, and then also the best performer. And that's the reference price. Why aren't we using this guy more, would be my question. Why aren't benefit packages designed to encourage use of these more efficient and effective providers more? Well, this is the type of information that a transparent system can provide. There's also data, patient-level data, to identify inappropriate use and fraud, and look at physician performance and profiling. And this is data that we pulled from our own database, looking at individual physicians providing stent procedures. And with the size of the bubble corresponds to the number of stents that they provide, and also the rates at which they provide them. You can see there are a number of physicians that are well above the 75th percentile, with several physicians doing huge volume. This guy may not even know he's such an outlier. This type of information can be vitally important to the health system over time. I also mentioned equity. It allows for fair treatment of patients. There's concern about diminished access over time for public beneficiaries. In an all-payer system, providers have the same incentive, whether you're Medicaid, Medicare, private sector, uninsured. There's a mechanism for financing your care effectively and equitably. And also potentially financing uncompensated care. In Maryland, we funded over $1 billion of uncompensated care per year and spread it across the rates of all payers. So generally, it's a much more equitable system. You also get a much more stable financial situation for providers, in that you've got prospective prices. They know what the price is. They can budget and manage more effectively, and they're protected against uncompensated care or payer mix shifts during the course of the year. And as a result, the bond rating agencies, Moody's, Fitch, S&P, consistently gave Maryland hospitals credits in their evaluations, and we tended to have the highest proportion of investment grade rated hospitals in the nation, of any state, because of this predictability. We were a tick below the U.S. in terms of profitability, but they put a lot of emphasis on this financial stability. And I mentioned also the narrower band of financial performance. MedPAC did a study on us that shows that we had a much narrower band than most any other state, 46 states in the District of Columbia, where we basically cut off the highs and cut off the lows and support the safety net facilities. And as I said, a really good track record over time of controlling payment levels. We need to look at payment levels because they are excessively high. History shows that we've done well, all payer systems have done well. The literature strongly supports this. And what it does basically is all payers systems restore that oligopsony purchasing power to the marketplace. It puts all payers in the same boat, and it eliminates that hesitancy or resistance to any cost containment measure of another payer, as we saw during the discussion of the Accountable Care Act. And the principal focus of all of this, of course, is to control costs, but there are other healthcare policy goals that can be met as well. And lastly, I think this is the most compelling thing, is nothing else works. This came out from the Congressional Budget Office, 2002 in January, which showed that most of the Medicare demonstrations haven't had much success. Little or no effect on hospital admissions, Only one of the 4 demonstrations yielded significant savings. That was the bundled payment demo back in the 90s for cardiac care. Other demonstrations that resulted in little or no savings, and they also made the observation that ACOs with little risk, just layering on these tools on top of fee-for-service, was a somewhat pointless exercise. By contrast, instead of looking at these marginal ways of trying to etch away at the cost system, the narrowly focused and inconsistent initiatives, both the RAND Corporation and the Urban Institute recently came out with an array of estimates of what types of initiatives has the most potential for savings. And lo and behold, AllPayer rate setting was by far and away the most effective. They projected over the next 10 years cost savings of 5.9% or $1.3 trillion. And that's supported by the evidence that we see of where costs are now for hospitals relative to the most efficient hospitals in the United States, which are about 9 to 11% below the US average. If we can gradually get there, you can generate savings of this magnitude. And AllPayer systems graphically, taking a look at that fragmented structure that I showed before, basically what it does is it provides this consistent platform to try to rationalize this otherwise chaotic stream of funding to hospitals. And that's what we try to do here in Maryland. However, this is price fixing. I mean, we agree, but we think it's better than the alternative. And there's a famous quote from Tom Scully, who was the former administrator of Medicare and Medicaid services. And this also came from Uwe's blog. He said he described himself as a dumb price fixer. Perhaps so. One would be hard put, however, to defend the current bizarre private sector price system that produces data such as those shown in the tables that Uwe's presented, prices all over the map. Dumber might be a more appropriate word for what's going on nationally. And actually, given a choice, I'd rather be dumb, particularly given that type of dynamic. So I mentioned before that there were weaknesses to rate setting, so I want to kind of wrap up with how we might look to reinvent a rate setting structure. Paul Ginsberg has hypothesized that an all-payer, consistent incentive type approach might actually provide an amplification of some of these bundled payment and global payment initiatives that are being pursued on a very narrow basis by CMS. And I agree with that. In fact, that's, I think, what we're trying to do in Maryland. One weakness of rate setting I mentioned early on, when you constrain unit prices or per cases, providers tend to do more cases. And that's, in fact, what we saw. There's also evidence that there may be a diminishment of quality in rate-setting states. Although the literature is somewhat mixed, recently we've seen that we've had high central line infection rates, high sepsis rates, high readmission rates. So we want to use our data and our metrics to try to tackle that, and we've started to do that, and I'll show you in a minute, to try to build incentives for higher value, both efficiency and quality. And then there's this issue of aligning hospital and physician incentives, and I have some ideas and thoughts there. And then there's the political arena, which, despite our independence, always was looming in the background and will continue to be problematic, needs to be addressed. So, incentives to do more volumes. As I said, we saw this in Maryland. You've seen this with the physician fee schedule in Medicare and the sustainable growth rate, where fees get ratcheted down, physicians tend to do more volumes. And it's this never-ending cycle. And it's interesting because we have had volume adjustments in our payment system. Medicare hasn't. And I think that was a crucial mistake in the design of the IPPS. And then, unfortunately, we gave up on our volume adjustments in 2001, and volumes took off. And I could show you evidence of this. This just shows from almost the day that we took the volume adjustments out, meaning we were only rewarded hospitals that only provided 85 cents on the dollar for increases in volume, trying to match up the price with their marginal cost or long-run marginal cost. In fact, a 15% fixed cost adjustment isn't high enough. I think it should be significantly higher to actually rein in this incentive to generate money on the margin. But hospitals responded to that incentive, and volumes took off, and that undermined our cost containment in the state. So moving forward, the focus from a policy perspective are in these areas. Keep the level tight. Change the structure of payment to embody more beneficial incentives to control costs over time, i.e. expanded bundles, episode-based payment, and finally global or capitated payment. Increase quality measurement and apply stronger incentives to performance on quality. We finally have outcome measures, process measures, experience of care that give us some semblance of idea of quality. And then finally try to align incentives across hospitals and physicians. And as I said, that all-payer system really provides a unique platform to be able to do some of this. Talk a little bit about the characteristics of episode-based payment. It involves transfer of risk from insurers to providers. So you have to be careful there. It moves along that spectrum, that horizontal from fee-for-service to per case to bundled episode, and then also capitation. And moving in that direction is positive. It ultimately is providing population-based rate setting, which is what Vermont is attempting to do, establishing expenditures for a given population and having hospitals be accountable for that. In Maryland, there were about 4 or 5 different things that we tried, and in the process of trying now. We moved the payment from per case out to per episode, including admission and all-cause readmissions. We negotiated 10 global budgets for rural facilities, I'll talk about in a minute. We developed a system for capitating suburban hospitals in more densely overlapping service areas. There are, of course, case rate arrangements that we've had for a number of years, include both physicians and hospitals. And then looking at other ways of aligning these incentives across providers. And then lastly, commensurate with all this, trying to increase the incentives for quality. Because clearly under these bundled payment structures, there are incentives to potentially skimp on quality, reduce service. We want to make sure hospitals are accountable for both their efficiency and their outcomes. I'll step through this quickly. Readmission, admission, we were approached by 3 hospitals in 2010 and developed an intra-hospital readmission structure that basically most of the hospitals are under currently, where they're at risk for all their readmissions. It's about 9% of system revenue. We provided seed funding to try to help them with infrastructure, and then also to develop a dashboard of monitoring utilization and quality measures along the line. So basically, previously, you had this very disaggregated system where a hospital got paid for every admission and every readmission, and the incentive was to do more. Under the new structure, we put a box around it and said, now you're at risk for the entire episode going out based on your old profile from the previous year. And hospitals are able to cut readmissions, get to keep savings associated with that. And if they exceed this, then they're basically capped at their previous year profile. I mentioned global budgets for rural hospitals. We call them total patient revenue, or TPR. We negotiated 10 of these arrangements. They're relatively easy to structure because there is an implicit matching of a population, because it's an isolated area, to an expenditure base, the hospital expenditure base. And so it's hospitals like Washington County or Western Maryland or on the Eastern Shore, where there isn't much overlap. They're dominant in their areas, and they are basically oriented towards treating that population. So we'd establish a global budget, a cap for them based on history, and then hold them to that. Link into various quality metrics over time, and then get them to treat the needs of that particular community. And that's truly much more population-based rate setting. It gives you a potential for a platform to do gain sharing with physicians. These are 3-year voluntary arrangements, but we're hoping that it will continue. And it was a substantial portion of revenue, about 10%, or about $1.4 billion. So global payment at the highest level, cap the hospital. Basically, that's the structure there. Now, the idea behind this was move toward regional expenditure limits, so that if you could cap hospitals in different parts of the state, you can set regional budgets for each of these areas, and then try gradually over time to bring that cost trajectory down closer to GDP growth. But bring them in at historical levels, give them time to adapt and change, broaden the incentives to include post-acute and physician, and then control things on a more regional basis as a function of what GDP growth is. Now, TPR is not applicable to hospitals in urban areas or suburban areas more because you can shed patients and do well under your cap on that type of structure. So you have to have more precise definitions of populations attributed to expenditures. The ACO model attributes patients to individual providers. We can do it on a service area basis through a method we call population-based rate setting, or PBR. Most of you know that as Pabst Blue Ribbon, which is what we were drinking at the time when we created this system. But it is something that can actually relate the two fairly distinctly for areas like Montgomery County or even North Baltimore, a group of providers on a regional basis. The target hospital would be at risk for their patients as well as all hospital expenditures in that region, and the system could be implemented or monitored through the HSCRC. And then the ultimate iteration of this would be actually, if we had the data across all payers at the claims level, to attribute patients on an all-payer basis to individual institutions, and then their expenditures would follow, and we could set caps for Johns Hopkins or Bayview or some of the city hospitals. The philosophy is, unlike the ACO structure, which gloms together different entities that have different incentives, like hospitals and physicians. The hospital under this structure assumes the underwriting risk. Physicians under like a primary care advanced medical home assume relatively little risk, but they have similar incentives, and that's kind of the philosophy. So PBR, population-based rate setting, would address most of the other areas in the state, and again, trying to get to that level of setting regional expenditures. We also did something with regard to quality of care, tried to develop outcome measures. I'll step through this quickly, but again, that emphasis on care. This shows our hospital-acquired infection and also complication structure, which reward facilities for lower rates of complication and penalize those with high. So here's infections due to central venous catheters, number of hospital-acquired infections, cost per episode, total cost, and so the hospitals that are here's the structure. It shows the better performing hospitals are at the bottom, the worst performing are at the top, and we reallocate revenue from the top to the bottom. It's revenue neutral system-wide, but we're devoting $20 million to this, and it gets people's attention. Recent outcomes results, we reduced hospital complications by 20% over 2 years. It's about $105 million, and cost savings, we hope, through reduced readmissions of between $100 and $200 million. So finally, we also need to focus on this value equation. We've been talking a lot about efficiency. Quality is equally important. We're measuring hospitals both on the efficiency scale, that's the vertical, high cost, low cost, and then we also measure on the quality scale through a broader portfolio of quality measures. Hopefully that's the way the Commission is moving, and then have incentives to try to push facilities down into that lower quadrant. Very similar to a cost effectiveness quadrant, although I think I have my quadrants mixed up here. We'll try to also address the misalignment of incentives, hospitals and physicians, which contributes to this huge variation over time. There are these federal laws, the anti-fraud and abuse laws, that really prevent cooperation between hospitals and physicians. Maryland's the perfect platform to try to get waivers from those laws, Stark, anti-kickback, civil monetary penalty. And you have structures like the state and the Blue Cross primary care advanced medical home models that set up the same incentives as the hospitals that are under these capitated models. So that has tremendous potential to align incentives. So that's what's happening in Maryland. That's my case for an all-payer system. And wrapping up, talk a little bit about challenges for the U.S. and Maryland. First, got to break the culture of volume. And then we've got to get this payment system out of the way. You can do both by these structures that I've mentioned. Open up these silos, reward hospitals and other providers for coordinating. It really involves towards moving back to a system of volume adjustments, but also capitated payment models, which are better than the ACO structures, I would say, because it's all payer and it doesn't have these conflicting incentives. And we emphasize moving out into the physician community and aligning the incentives with the various models we have now, which will weed out inefficient providers. We have more physicians than we need, and that will be something that will be needed to be addressed. So real and meaningful cost containment also means avoiding regulatory capture. The political side of it is equally important. Every state has a hospital in every legislative district, and there is tremendous amount of political firepower that goes along with market power. And local politicians see healthcare as an economic engine to increase job growth in the United States, when in fact, because it sucks so much out of the rest of our economy, it's probably more that we get 1.2 jobs lost for every job we add to the health sector currently, the way it's structured. And that tremendous political influence, I think, undermines the ability of us to confront this overall comprehensive problem with courage, because every dollar of cost containment is one less dollar of income to providers. And that's a challenge that's going to be very difficult to overcome. So it's vital that we make a rate-setting agency insulated politically, independent, and free from any potential conflict of interest. That's what they've done in Vermont. There's one board, which is a volunteer board. It reports only to the governor, and it is completely isolated from the providers and also from the politics up there. So I think they have a tremendous advantage. So implications, final thoughts. I don't think we've broken the back of healthcare costs. And U.S. pricing is what Churchill described Russia to be in 1939, a riddle wrapped inside of a mystery, inside of an enigma. That's something that we've got to break. The main culprit is market power, the lack of market power. I mean, if you don't believe that, just look around. Look at Germany, Japan, Netherlands, Taiwan. Every other industrialized country has bolstered the purchasing side. And then it's rationalizing both the level, constraining prices over time, and then expanding the structure of payment, which are the keys to delivery system transformation. Payment reform has got to be comprehensive. It can't be just Medicaid, Medicare cutting over time. That's not going to save anything, as hopefully I've illustrated. And we need a solution as soon as possible. There are large economic and social consequences. And final thought, more capitated, the better. Vermont, Maryland's moving in that direction. Much stronger incentives. Realistically, there are only a few states that will likely adopt this type of structure. I think there are only some limited tolerance for government intervention, although I've seen studies that show that over time, the public wariness of government intervention on the health care side is declining. So one middle ground approach to restore market power might be to legislate maximum payment levels for private sector in various states, just as some multiple of Medicare. Make it 150% of Medicare. When large health systems are charging 2, 3, 4 times what Medicare is not charging, getting paid. So anything that can be done in that regard that's incremental, that can try to shift this balance of power back to the purchasing side, I would argue would be beneficial. And with that, I'll stop and take questions. Thank you very much.
So if you have questions, we're going to try to use the mic as soon as it comes on, so that way folks that are on the webcast can hear the question as well.
Yeah, I don't see anybody raising their hand, so I must have stunned everyone.
I imagine that some of the greatest political resistance to an all-payer system may be from those who would lose their income from the efficiencies brought about by the system, particularly in the administrative costs. I say this as a health policy student who probably my salary might contribute to that overhead. So could you speak to the early 70s, Maryland's experience with the absorbing those jobs in the economy?
In the early 70s, absorbing those jobs in the economy, could you clarify that a little bit? I'm not sure I fully understand your question.
So I imagine that there were people and their salaries would be classified as healthcare overhead. And then as you saw the AllPayer system introduced, you saw greater efficiencies brought into the system, and instead of some of the highest costs in the system, you were down to like 3% or however many.
Yeah, we got down to about 11% in 1993.
So where did those people go in the economy? Where were those jobs? They didn't become unemployed. How did Maryland absorb them? Because you don't want a whole bunch of people becoming unemployed. The legislators won't enact.
Yeah, well, I don't know that it was identifiable. One of the things about this structure is that it was gradual over time. We didn't pop from 25% above to 11% below. It was gradual over the course of that period, 76 to 93. And so I can't really fully answer your question because I don't know where those people went. But over that period of time, either through attrition or through retraining, they just migrated out of the industry. The achievements that Maryland made are significant, but they're nowhere near the magnitude of reducing healthcare waste and expenditures of 20 to 30% that we need to. So it will be a much more important question. What happens to all the specialists that we don't need? I don't know. Perhaps they're retrained as primary care physicians. But there are a lot of specialists out there we don't need, to be quite blunt. And so it will be an issue. Hopefully we will be able to encourage more people to go into primary care, become nurse practitioners, physician assistants, because that's what we need. And that's the reallocation of resources that need to take place. Yes?
It seems that the going thought is that bundling payments would actually improve quality of care because people wouldn't want readmissions. You seem to be saying a little bit ago in your talk that there would be a sort of trend towards skipping on quality. Can you talk a little bit about that more?
Yeah, I think in one hand you're exactly right. When you expand the breadth of payment, you have the potential now to coordinate more and benefit from that if you can take waste out of the system. But the incentives purely in that structure alone is to reduce use. And there's always the potential that it can be overdone. You could, for instance, with readmissions, if there wasn't some monitoring or some quality of care measures that people were held accountable for, people could bounce back to the ER, they're just bandaged up and sent home. And the hospital benefits from that. Well, you don't want that type of outcome. So you have to monitor, reward hospitals and health systems for better outcomes along with that, to go hand in hand with this now newfound autonomy to coordinate. So it needs to be both. But you're absolutely right. It now opens up the spectrum of being able to coordinate care, and that should lead to better quality. Yes?
So I'm not sure I believe there would be much job loss, but there may be reduction in the growth of jobs in healthcare, certainly. Do you anticipate any other potentially deflationary effect? Could such a system, which I think has many advantages, for at least a period of a couple of years, have a negative impact on the overall Maryland economy?
Well, I think to the extent that we rely on the healthcare sector for job growth, yeah, maybe it will be a bit. But I would tend to agree with you. You won't see large-scale taking folks out. It will moderate the rate of growth of healthcare costs and employment. I just think it needs to be done immediately, but gradually, because it's best to avoid large-scale disruptions in the healthcare industry. I think what you'll see is a consolidation of hospitals. We have more hospital capacity, far more than what we need. And over there, like teaching costs and research and so on, those need to be supported. But the academic structure does not necessarily exemplify the best model for overall efficiency, I don't believe, the way it's configured now. So eventually things will have to change.
We have one question that came in online.
The question from online is, I'm unclear what you're saying about the role of emerging accountable care organizations in the cost control battle. Why do you view them as part of the problem or solution?
Well, I think what the big criticism of the accountable care organizations, or maybe not big, but a criticism is that in a structure where the incentives are directed toward consolidation and increasing market power, ACOs now provide additional incentives for hospitals and physicians to, again, muscle up. And to the extent that they have very limited risk on the side of the ACO and still are operating largely under a fee-for-service system where every incentive is to price up to the private sector, ACOs just feed into that dynamic. And that's a problem. Plus, the incentive structure for physicians and hospitals within the ACO are disparate, I would argue. Most of them, again, will be still operating under fee-for-service. And it attempts to glom them together into one governance structure and just presume that that governance structure is going to get them to work together around a set of very weak incentives in a very narrow area. And I don't see that as effective over the long term. The incentives are right. It needs to be comprehensive. It needs to be all payer and also recognize the different tolerances of these groups for accepting underwriting risk. Physicians can't accept underwriting risk, so they're forced to be in with the hospital, and it just won't work. And that's my humble opinion. Yes.
My question is a little bit skeptical, just from a national level, because you've mentioned many times about how basically the way that it's set up is there's a lot of people getting rich off of the ease at which the money can be contributed to healthcare practitioners. So my question is, realistically, in the next 10 years, I mean, what's your realistic expectation of this? Because the power dynamics are so skewed politically and economically between the people that are getting healthcare and the people that are receiving the benefits of the system as it is.
Yeah, I think that's the real challenge. I believe that you'll get a few states like Vermont, maybe Washington State, Oregon, Northeast, Northwest, that will move more in this direction and then have a great deal of success for it. So you'll see the disparities there. Hopefully the federal government gives these states enough flexibility to move down this road. Ultimately, the disparities will get so huge and the financial burden, both the access issues will widen out, those graphs that I mentioned, and we won't control spending, that the government will have to take over. And they will probably take over in some sort of single payer. And maybe this doesn't happen for 10 years, but when we're up above 80, 90% of debt to GDP, they got to do something. I just maintain nothing else will rein it in, except for a single payer, which I think has its weaknesses, or something that's more comprehensive that gets at this market power. And it really, as Peter Orszag said, it is really the future of the country to a large extent. I believe that.
Do you think 10 years is like a reasonable timeline?
Well, you could project it out. I mean, I think in 10 years' time, we will likely be up around 80, 90% of debt to GDP. That's assuming we don't raise taxes. But there are negative implications to raising taxes, too, from an economic standpoint. So I think the real key is when business gets behind this. And eventually, business will have to support this because they will get to a tipping point as well. And there may be disruptions, too. I mean, people may just drop insurance, the employers, and say, well, let the exchanges pick it up. And so it could happen sooner, like 2015, 2016. There will be some cataclysmic things that will happen, and it could accelerate in that time frame. So I think it's less than 10 years.
Let's take one or two more questions.
A related question. So can you speak about how does HSCIC work with the CMS? Because to me, it seems like CMS should have every incentive to work with you to contain the cost for private insurance. Otherwise, they will continue to see providers decline Medicaid and Medicare patients. And also, if that's true that they should have incentives working with you or any model with AllPayer's system, can they be a political force to help other states to overcome the hurdles and pick up the model?
Well, I think generally they do have an interest in working with states like Maryland and Vermont. And there is this Center for Medicare and Medicaid Innovation that was set up through the Accountable Care Act that was, they've got Pioneer ACOs, bundle payment, other primary care advanced medical home models, things of that nature. So they are experimenting. Within that structure, they're very, very interested in multi-payer applications of these innovative payments. The problem is they need to do it sooner, faster, and have more of an emphasis on the multi-payer. So they're interested in working with Vermont, potentially have Medicare participate in a payment model, make it like AllPayer like Maryland. But, they haven't quite changed their mindset to think big. They're still thinking pretty small, and my worry is they're running out of time. Plus, there's this issue of data. They won't even allow Medicare data to be used broadly for these payment models. They're very restrictive in the use of the data for Medicare, which is crazy. If they want to stimulate these things on a multi-payer basis, you need Medicare data into your structure, your all-payer claims database, to be able to model this out and develop multi-payer strategies. So eventually, hopefully, they'll get there. They're held back by Congress, though. Congress is not necessarily freeing up the purse strings or the ability to, flexibilities. So one more, did you say, or?
I was wondering, and you mentioned already, what would be the impact on the competition in the market? You mentioned the consolidation among some providers. Also, I was wondering, have any provider entities left the market in Maryland, for example, after the AllPayer system implementation? And the second question would be the impact on adoption of new innovation technologies in Maryland. I'm not sure you got any parameters to measure that, but what was the trend in terms of adoptions of medical devices or in terms of investment?
Yeah, I don't have any empirical evidence to comment on the last one. I have read just general literature about rate setting, whether it impedes or stimulates innovation and technology diffusion. The general literature indicates that rate setting states tended to impede diffusion of technology. I don't know. They roughly, the review of the literature I saw said about a 2/3 rate of the rest of the country. So there is, for better or worse, some sort of constraint on technology diffusion and adoption that may have both negative or positive connotations. As I mentioned, there's some concern about quality in rate-setting states too. But at the same time, technology diffusion also is a big cost driver. So back and forth there. In terms of competition, I can tell you that there were some for-profit hospitals in Maryland in the early 70s, 80s. They all left. And largely because their strategy is to play more kind of the revenue game to try to maximize profitability as opposed to managing costs. Now I think they're doing both, but it's like buy up hospitals in a certain area and then jack up prices is sort of the modus operandi there. I think they could do very well in this environment, for profit, more incentive to actually reduce costs, and you're under a target, so go to it. It's just like most other industries. So for whatever reason, you've seen that type of flight from regulation. And if they figured it out, they should come back. But maybe they will when things get tight elsewhere, particularly on the public side. So, well, thank you for sticking around. I know I'm probably eating into your day here. And I wanted to mention this is the Hal Cohn, who was the original founder of the Health Services Cost Review Commission, who passed away, unfortunately, earlier this year. But thank you very much, and it's really been an honor to be here and be back in front of you.
There's a reception out to your right of the exit, and you'll have more of an opportunity.